Welcome everybody to Long COVID, focusing on long-term effects of COVID-19 on CHW work and the community CHWs serve. So before we go into our webinar and everything that we have for you all today, we just want to quickly just go over some of our translation controls for everyone. So this meeting will have simultaneous Spanish interpretation. As a participant, you will need to choose a language, either English or Spanish, to listen in Zoom. If you do not choose a language, you will not be able to hear the presentation, which is why we're all here. So instructions in your meeting settings / webinar controls, click interpretation, click the language that you would like to hear, and of course optional, this is optional, to hear the interpreted language only, click mute original audio. And you can see in the slide just a visual representation of everything that I just mentioned. So once again, in your meeting / webinar controls, click interpretation, click the language you would like to hear, and of course that optional choice to hear the interpreted language only, click mute original audio. And just some more closed captioning instructions for everyone. The Zoom webinar will have automated closed captioning, and closed captioning can be turned on or off throughout today's webinar. And to manage closed captioning on your computer or laptop, and then John, you can actually go to the next slide, which is the closed captioning one. Click CC live transcript, select show or hide subtitle to view captions. And you can also select view full transcript to see the entire written transcript from today's webinar. And to manage closed captioning on your mobile device, which is a reality in today's world, go to your Zoom controls and click meeting settings. You can then use the toggle button, as you see in the picture there, to turn off or on closed captioning. Right. So welcome everyone, and welcome to Long COVID, like I mentioned before, focusing on the long-term effects of COVID-19 on CHW work and the community CHW serve. The Envision team is super excited for today and grateful once again to be in community with you all and share this space and have the opportunity to be working alongside you as we dive into some very important information and findings around long COVID. Once again, my name is Jamal Perry. I'm the trainer with the Envision Equitable Healthy Communities Training and Technical Assistance Center. I'm currently located in Milwaukee, where I do have deep roots in community here doing CHW work. Most of the CHW work that I've been doing or was doing, still doing, will probably forever do, is in LGBTQ+ health promotion, as well as anti-violence advocacy and equity, as well as sexual health education. And I'm also the CHW Council lead with Envision and work closely with our Envision CHW Council. And for those who are wondering who Envision is, so the Envision Equitable Healthy Communities CHW Training Center is composed of community health workers and community health worker allies who work together with financial and administrative support from the CDC to elevate the role of CHWs in COVID response and recovery. Envision Equity supports the CDC-funded program CHWs for COVID response and resilient communities, which uses the acronym CCR, which most of you might know. And you can find details about this initiative and who the funded organizations are at the CDC COVID Community Health Workers website. And of course, Envision has been developed for CHWs by CHWs, and our project encompasses the CHW movement as a whole and trains and supports CCR recipients and their partners, CHW programs and CHWs, concentrating on capacity building and sustaining a strong and capable CHW workforce. And just a little bit of Envision news here. So our partners and our at South Carolina State, CHW is hiring coaches, and of course, any other Envision news or updates you can always find at our Envision landing page, which will drop here. And yeah, you can find all updates about Envision, more updates about who's hiring and what these jobs look like for all of you and your network. So definitely check out our Envision landing page. And of course, our operating agreements. So we do recognize much of today's webinar will be content delivery and pretty content heavy, but we do have some operating agreements specifically around Zoom. So remembering to stay on mute when you are not talking, and remember to use the chat box for questions, and we'll continue to keep track of those questions throughout the webinar and make sure we are able to come back to those, and any questions that we don't get to, we will be able to follow up with you all in an email or through AMP. And of course, use the chat box to network and talk to one another. It really is a space for that as well, to ask us questions, directly message each other, because we all are in this work together, and many of us may know each other or have questions for each other or don't know the work that we're doing. So definitely use that chat box to connect with one another during this time. And of course, do what you need to do to take care of yourself, because that is important. We are still in COVID times. COVID is still very real, as we'll learn in this webinar, as well as a plethora of other things going on. And we're just on Zoom. So we do recognize if folks do need to step away or grab water or take bio breaks or do whatever you need to do to take care of yourself. And just to quickly go through our learning objectives real quick. So long COVID definitions and prevalence nationally, along with tribal and state examples, will be given to CCR recipients. Participants will have a greater understanding of the impact of long COVID on vulnerable communities. Program management will gain greater insight on how to address long-term COVID effects in vulnerable communities, and recipients will have a greater understanding of CHW and CHR needs around long COVID. And to quickly go through the agenda as well. So we're going to, of course, which we already done, gone through our Envision introduction and news, and go through a long COVID introduction, a long COVID panel with our experts and our presenters, which I'm super excited for. We'll have time for Q&A, and then we will wrap up. And then you can go to the next slide. All right, so long COVID, what is it? Who is affected and what are the risks? So long COVID, post-COVID, long haul COVID, COVID post-acute, and chronic COVID are all terms used to describe individuals that have been affected by COVID-19 and are experiencing long-term effects from their infection. According to the CDC, post-COVID conditions can include a variety of ongoing health conditions that can last for weeks, months, or years. There's no test to diagnose long COVID, and the variety of symptoms make it difficult for healthcare providers to recognize post-COVID conditions. There are many factors that contribute to people or certain populations experiencing long COVID, and this include those who experience more severe COVID illness, especially those hospitalized, people who had underlying health conditions prior to COVID, and those who did not get the vaccine. And finally, the various health inequities in many vulnerable communities that our CHWs serve are at a higher risk of developing long COVID. Okay, so, and before we hear from our panelists today, we want to share with you a quick 10-minute video from a Facebook Live from Dear Pandemic. For those not familiar with Dear Pandemic, it is an interdisciplinary all-women team of researchers and clinicians whose mission is to educate and empower individuals to successfully navigate the COVID-19 information overwhelm. It's a lot of information, a lot of things out there, and Dear Pandemic do what they work together and do what they need to do to get that information to us as clear as possible. And the live will address long COVID inconsistencies and estimate variations in risk factors and their causes. So, all right.
So a question about long COVID. So Lorraine from Vancouver, here's an example. She asked, for people 65 to 70 and other ages who are triple vaxxed, what are the chances of getting long COVID? And is there a difference amongst genders? And I know this is a really hard question to answer super specifically, so maybe you can just speak more broadly to what we know about how common COVID is and what are the different risk factors and why the estimates vary so much.
Yeah, so I think I'll start with thinking about why estimates for long COVID might vary so much study to study, because I think it's helpful to think about what goes into studies in determining that estimate in the first place before we kind of make an overall assessment of how common long COVID is. And then we can circle back to sort of what the sort of identifiable risk factors are so far. And so, when we're thinking about an estimate of long COVID from a study, I think we have to think about the points we have to think about is how that disease was defined and how it was counted, and who got counted as having long COVID, how that researcher might have sampled the population or determined who they would ask from the population if they've had long COVID, the role that the way they collected that information may play in terms of whether it was voluntary through an app or through hospital records, the role of the timing that when they asked, because we've had different variants circulating at different times, which may have a different risk for long COVID, and then sort of the geographic location where the study is being conducted as well, because there just may be genuine differences in the prevalence of long COVID in different populations. So in terms of thinking about how we count the number of people that have a disease or a health condition, we have to set criteria that constitutes what is a case of that condition or a case definition. And because long COVID is relatively new disease, it feels like we've been in the pandemic for a decade, but in the grand scheme of things, it's really been an evolving understanding of what long COVID is. Our definition or our thoughts about it have changed over time or have evolved. And so, now we may hear terms like post-COVID conditions or syndrome, long haul COVID, post-acute sequela of SARS-CoV-2 infection, right? So there's a lot of different terms that are also being used. And the World Health Organization sort of defines long COVID as a condition that occurs in individuals with a history or probable or confirmed SARS-CoV-2 infection, usually 3 months from the onset of COVID, with symptoms that last for at least 2 months and can't be explained by an alternative diagnosis. CDC, on the other hand, thinks about those symptoms that are at least 4 weeks after infection. And that's like sort of the earliest when you could start to distinguish between just the acute symptoms of COVID versus post-COVID conditions. And then in the UK, the National Institute for Healthcare and Excellence defines duration as less than 4 weeks, 4 to 12 weeks, or longer than 12 weeks, with the last two categories counting as long COVID. So the first thing to do is pay attention in the study that you're looking at. Well, how did they count people? How did they define COVID? And is that the same as how they define that in another study that you're comparing the estimates between? In general, the symptoms that are sort of now thought of as common or potentially what people with long COVID experience are kind of wide ranging. So there's more general symptoms that are tiredness or fatigue, fever and sort of symptoms that get worse with physical or mental effort, then there's a range of other body systems that are impacted: respiratory and health symptoms, neurological symptoms, digestive symptoms, and other, body symptoms like joint, muscle pain, rash. So, there's a long list of symptoms that maybe are relevant to what people with long COVID are experiencing as well. And so there could be variation in sort of the symptoms that get asked or the way these questions are asked across studies. So another challenge then with figuring out how many people have any disease of interest is related to how you sample the population. Ideally, we would ask every single person, like in your city or state, if we wanted to know everybody that was experiencing COVID, long COVID, but that's generally not possible, logistically really challenging. So then we have to choose how to administer a survey or collect that information. And it's not always going to capture a representative slice of the population. And so, we also think about who participates in studies as well. So there's, if a study is based off of a convenient sample of people that say, yes, I want to, know about long COVID, or I had long COVID, so please do ask me, that's totally different than sort of a sampling technique or asking people, who, regardless of maybe their interest in giving that information. And so then we also have to think about, as I started to mention, how information is collected. So are people using medical records to ascertain symptoms? Well, then that's really restricted to people who seek care for long COVID or for symptoms in general. Is it a app that people use on their smartphone to report symptoms? Well, that may be limited to people who use smartphones or who want to participate in those types of surveys, right? So I think paying attention to these ways that we collect data and who's included in the study can give some clue as to whether the people who ended up included might tend to be more likely to have had COVID or to have long COVID versus not. And then the time frame when the study was conducted in the cases were, detected matters too. I just posted recently on Dear Pandemic about how the risk of long COVID may differ by variant. And so maybe, Chana, you'll put that.
Yeah, I can put that link in.
Chat. So 2 studies that came out, one using population representative data from the UK and another using data from an app, so not necessarily population representative, both found that the risk of long COVID was higher with Delta than Omicron, but that the BA2 variant of Omicron, the risk seemed a little bit higher than BA1, and we don't yet know about BA4 or 5 or any to yet emerge variants. So I think paying attention to all of those, characteristics of the study can help us figure out, if we're really comparing apples to apples when we're looking at different estimates from different studies, and can also help us evaluate, hey, is this study sort of a likely representative of the entire population, or is it there's some selection into who participated?
Yeah, so I think you're going to get into this, but it sounds like you're going to get different numbers because different populations will have a different risk of long COVID. People are defining long COVID differently in different studies. So both of those can contribute to getting different estimates, and not to mention the variant.
Yeah, so these are all reasons why in one study you might see 50% of people get long COVID or down to 5%, and so keeping all these factors in mind. And there's actually a really nice piece that came out from Stat News that I have here if you want to also link to that in the chat, that sort of gives a good summary of a lot of these points that I just raised. So given all that, getting back to that, the other part of the question is how common is long COVID then? I think we had a recent study in the US of 60,000 adults carried out at the CDC in June 22 that found 1 in 5 cases reported yes to the question, did you have any symptoms lasting 3 months or longer that you did not have prior to having COVID-19? And they also estimated that 7.5% of all adults, or about 20 million people, are living with long COVID right now. This is a survey that they may have had some issues with response bias in terms of not being quantitative, and that's contrasted with a study that came out in the UK a very population representative sample from the Office of National Statistics, and that estimate was that 2.8% of the population were experiencing self-reported long COVID or symptoms that had lasted more than 4 weeks after their initial infection.
Great. Okay, so hope that video definitely was a good insight on some of the findings around long COVID, and you too can use this video to educate communities that you all are working with around long COVID. It's definitely a great tool for folks who are working on the ground. And in the chat for our CCR recipients who are in AMP, these resources will be live in AMP, or they will live in AMP, and there will be other community level resources and information as well. Also, a reminder to you all have access to the STL calls, and there was an email that was sent out last month, which did have additional programmatic and data lens resources around long COVID, and these links, along with other links from Dear Pandemic, will be living in a single folder that is accessible on the Envision page. And I think that will be dropped this moment as well. And that will have the link to this video, other videos from other resources from Dear Pandemic, as well as more of those programmatic and data lens resources from the STL calls, and many other resources that you all can use within community. Definitely look for that. And now we're going to dive right into our panel and their findings and the overall work around long COVID. And this includes a tribal lens and state Pacific lens. And our experts include Dr. Antoinette Francis Sharia from the University of South Alabama, and Sarah Reed Trasilius from the Ho-Chunk Nation Department of Health in Arizona. So now I'm going to pass it to Sarah, and we will start.
All right, let's see. Aho and welcome, hello. That's our local greeting in the Ho-Chunk Nation. My name is Sarah Trasilius. You did a great job at presenting my last name. It's a married last name. It is really challenging to pronounce, so I think you did a really great job. So like I said, I am the epidemiologist for the Ho-Chunk Nation, and today I'll be sharing our experiences and assessing the impact of long COVID among our tribal members. So just a little bit about me before we get into the presentation. I think it's really important for our presenters to know where I'm coming from, if there's any biases that I might have. Dr. Semenek in the video that you presented brings up some really good points about related to studies and research. So I like to be as transparent as I can. So I actually came to the nation in the middle of the pandemic back in January of 2021 when I was still in graduate school. I specifically work for the Department of Health, and the nation has several departments. So I am just located centrally, Department of Health. We have a clinic and also a health department. So it works a little bit differently than some non-tribal governments. If you want any information about us and the work that we're doing, I have the link in the right-hand side. You may not be able to see it if it's getting cut off by the border. So my background is in sociology and epidemiology, and I was really interested in rooting work in social and environmental justice and using findings from research to make actual change in communities. And the last and important thing about me is that I am non-tribal. So like I said, it's important for you guys as you're watching to recognize that I am representing a tribal community and trying to gather and share tribal knowledge, even though I am non-tribal. All right, next slide, please. So here's our agenda for today. I will just briefly discuss some of the context of the pandemic and how we've transitioned from measuring COVID-19 case burden into more of a period of recovery and resiliency, specifically around long COVID. So we'll talk about the study that we did, what we learned, how we're applying it. And we've already mentioned this before, but this is just a disclaimer in the terms of language. Sometimes I use long COVID, sometimes I use long hauler. Typically in our community settings, we will use long hauler because it's a little less technical than some of the other definitions that we've talked about before. Great. Next slide, please. And again, just one more context of overview. So this is very important to share about how the nation works. So tribal government is different from non-tribal government, and of course, each tribe functions in different ways. So we are located in the state of Wisconsin, so you see the two maps on the screen. And although the majority of our members live in Wisconsin, this is about 70%, they are located all across the United States. And historically, we have traditional land that goes from Wisconsin, Minnesota, Iowa, Missouri, and Illinois. Now, we do not have a reservation, unlike some of the tribes. So we have trust land that includes government buildings and housing communities and other land. But in the Department of Health, we have a designated geographical area assigned from Indian Health Services. So that is the map that you see on the right-hand side. So basically that says in these specific counties, we are required to provide services and we have to report on specific health outcomes and program activities. So in the state of Wisconsin, we have 15 counties, which you see on the map. We have one county that's in Minnesota, which would be on the left-hand side, which is not on the map. But however, regardless of a patient or community member's geographical location, we also have to provide services for anyone that meets the criteria of our service population. So this includes Ho-Chunk tribal members and their families, other tribal members and their families, non-Ho-Chunk, and employees who could be tribal or non-tribal. All right, next slide, please. So keeping in mind, we have the specific service area we have to report on, but we also have to include anyone that meets this definition of our service population. Data and research becomes quite complicated very quickly. So when COVID first started, we tracked the COVID burden using these public dashboards. This is still on our website. We have one for COVID cases and we have one for vaccines. And so the dashboards often included common questions we get from community members, other leadership like legislative and what we call leadership, so our executive directors. And then internally, you see this little snippet here of the report. We had these internal meetings of in-depth EPI meetings to go over the COVID information, making an assumption that this is the burden. However, we knew the entire time that this wasn't the actual burden of COVID per se, because we weren't measuring the lived experiences and the impact in our communities. So then what we knew about that is we needed to do something more deeply to ask about the impact of COVID. So next slide, please. So in the state of Wisconsin, just to give a little bit of context, we see communication going around about long haulers, long COVID, and at the same time, trying to transition into a period of recovery and resiliency. But we're still trying to manage new caseloads. We had the Omicron variant at the time, the time that this study was conducted. We also saw on the state that there were clinics opening up, long COVID clinics, and it became very challenging because not only was it a new virus, but the impact on the individual was so specific because of the type of symptoms they had, the frequency, the severity, but also what type of access to resources do these individuals and families have? Because the access to these resources will then impact what recovery would look like. So most likely recovery is going to look very different in a non-tribal and tribal setting, probably an rural versus urban, whatever kind of other comparisons that you have. So because of all of these factors at play, our legislative then asked us, how many members have long COVID? And we're like, well, we don't really know. The state was not doing surveillance at the time around it. So we had to do a study to get this number. Next slide, please. So what is the so what? So we've kind of already discussed this before, but long COVID not only impacts your physical well-being, but also things like mental, spiritual, cultural, social, financial, and so on. Essentially, it just impacts your way of daily living. And additionally, when a family member is impacted, it impacts all of the family. And this is particularly so in kinship cultures or multi-generational households. So it was also important to try to capture these family impacts as well. And then because of this, ultimately, the study changed from just a long COVID study to an impact study, where the goal was to see, to understand, the impact on COVID and long haul COVID on daily living, and to see what we could do as an organization to try to support recovery through programs and services. Next slide, please. So initially the study was set up as a telephone-based interview, which has its own limitations. This was primarily driven by the context at the time with the pandemic, and also for staffing and other resources. And again, we only assess members living in that service delivery area, which is the map that I talked about in the beginning, for a multitude of reasons, but keep that boundary in mind when we're talking about results, because it impacts who the results can be applied to. And the other thing is we have so many counties, and we want to make sure that each county is accurately represented. So what we basically did is we had a target sample number. If that county represented 30% of the population, then the sample from that county should also represent 30% of the population. So the major questions that we wanted to know was if someone was a long hauler or not a long hauler. If they were, did you currently have symptoms or did they stop? And this was helpful to try to estimate what type of resources would be relevant at the time, and then what other support that they currently had. So that when we ran the analysis, we had these different groups emerge, which was really helpful to see if there were differences in impact based on how somebody identified, like I said before, if they were a long hauler, not currently have symptoms, or have they stopped. Next slide, please. So now this slide is representing for all participants, long hauler or not. So the first thing that we wanted to do was see how we asked participants to rate how their COVID-19 infection impacted their physical health and mental health. So for those that rated high impact, we see some of these major associations that had emerged. So we see the first of not having enough money to cover basic needs or living paycheck to paycheck, experiencing symptoms for 6 or more weeks, which we defined as long COVID. And again, something important to consider is the definition that we use for long COVID was the one that the CDC had proposed. There were a lot of different definitions at the time. The third thing was living with a disability, at least one disability, or having at least one underlying health condition. And for age, adults age 35 years or older, or households with 3 to 4 people. Now, the age gets very interesting because we know that everyone was impacted in some way or form. And you'll see that as the slides continue, the differences by age, and it just so happens statistically, because of the sample pool that we had, we see that adults 35 and older were the ones that had the most statistical significant impacts, although everyone was impacted in one way or another. Next slide, please. Okay, so again, we're looking at all participants, long COVID or not having long COVID. So the first one is talking about physical health. And so to read this, because this might be a little confusing, so you see these specific impact types, and then you see a percentage behind it. What that basically means is, so for example, we see being hospitalized for COVID-19, 53%. That means 53% of our participants who said they were hospitalized for COVID-19 also rated their physical impact as high. So you see kind of a distinction right away. We see being hospitalized for COVID, feeling like a burden to others, needing additional medical care. And then on the left-hand side, we see a lot of different school types, relying on others. So for physical health, the largest thing I think you'll see is the impact on age, where most often younger persons rated low impact, and high impact often included either adults or people who had long COVID, regardless of age. Next slide, please. Okay, so here's in contrast for mental health. Now, there wasn't a big difference by age here. So there were actually some impacts that both high and low persons shared equally, which was very interesting. And that would include feeling isolated or lonely, having to ask others to complete tasks, and stigma or discrimination for having or had COVID-19. So what we basically got between these two differences is that the impact on physical health was a little bit more predictive than on mental health, particularly for age. Next slide, please. Okay, now we're specifically into long haulers. So we see that in our sample, we had about 22% identify as an ever long hauler, which means they currently have symptoms or they stopped. And so this estimate was similar to the WHO prevalence that I had shown you before. But again, the sampling will definitely impact the numbers that you're getting. The majority of our participants, about 18% currently had symptoms, and the average number of week symptoms were experienced is about 32.5, which is a long time. That's over 6 months. And the range was 6 weeks up to 2 years when the study was conducted. So the people with the 2-year mark, those are people who were, I call them the original COVID cases when the pandemic first started. So we still had people experiencing symptoms at that time. We also see some differences between people who are ever long haulers and never long haulers, specifically for being hospitalized for COVID-19, receiving additional medical care for COVID-19. And for age, when we categorized it this way, we saw that elders, so that's people who are 60 years and older, they were significantly different. However, when you look at current long haulers, the age pattern changes, and we see that youth were also having that impact. So this is when we're including historical long haulers and also current. And then the other thing that was statistically significant was having at least one booster dose, but it didn't matter if they got it before the infection or after the infection. So we're not quite sure the association with that yet. All right, next slide, please. And so here is for us, this was the set of people who currently have symptoms. These are the current long haulers. So we see that it's important to know, because this would help us predict what type of services and support people would need. We already see the difference in age, where 35 to 44 has the highest percent, around 24%. Those that are 60 and older are not quite different. It's about a 2% difference, which is really not that large. But when we are looking at the combined graph of the ever long haulers, that pattern, which was much more present, it was kind of like this, just straight up. And this is very different because we see the youth impacted, and we also see younger persons impacted. At the same time, we were getting hospitalizations for people who were younger, when before it was just elders. For finances, again, majority reported a low household financial perception, which is they live paycheck to paycheck or they can't pay their bills. Social support, which is very important for everyone, but also particularly for Indigenous cultures because of the reliance on the community and family. They rated slightly moderate for social isolation. So that is your access to resources. So if you were sick, do you have someone that could help you out, and for how long? They also rated slightly moderate for social loneliness, which is, do you have meaningful connections with people? We see for healthcare access, the majority of patients are very good for health insurance, access to regular care, affordable care, a place where you feel like you belong. For household responsibilities, we see that over half, about 66%, did live with children. And we see for health status, over half are living with at least one disability, and about a third have at least one underlying health condition. All right, next slide, please. So now that we have this information, what are we going to do with it? So like I said before, we have a clinic and we have a health department. So this approach is a little bit different than what some of the organizations might do. And so I think on the clinic side, oh, my lights just went out. I'll just keep going in the dark. We have that contrast, I guess, going. So what we were doing on the clinic side was just essentially trying to set up a process to have an integrated treatment plan, just being like, what is our definition? What kind of symptoms are we screening for? What other resources are we going to have? On the public health side, it was a little bit more challenging because we found that, you know, things like education, housing, food are all impacting someone's well-being, but we aren't necessarily responsible for them. So what does that response look like? So some of the things that we pointed out was education on what long COVID is, because a lot of the text comments from the open-ended responses were saying things like, we really don't think it's a real thing because we didn't get it, or we got it and it wasn't very severe, but I see people are dying. We talked about vaccine confidence in general with the importance of boosters to help reduce the severity or duration of symptoms if someone were to get COVID. We also we have community health representatives. They're trusted sources in the community. We thought they would be the best source to share the information of what we learned from the study, and also share what current resources that we have, because some of the responses in the study were asking about, I think this would be a great resource, but we already had them present. There are two things that are highlighted in here, and those are things that we talked about doing, but we weren't able to because of current staffing and resources. So we thought it would have been very meaningful, especially from an Indigenous perspective, to have this video campaign that was like a storytelling narrative about people's long COVID experiences. The second thing was that now that we have the information, what should we do with it? Ideally, it would be community-led. The community would tell you what their concerns are and how to apply the information. So those would be those listening and facilitated sessions that we were ultimately not able to do. All right, next slide, please. All of these different characteristics of your information that you are receiving and how it can be applied. So I think the biggest thing is that in an ideal world, especially for a tribal community, we would have wanted to elevate our community health representatives so much more. In our community, storytelling is a major way of sharing knowledge, and sharing knowledge requires trust. So oftentimes, the best turnout that we have for feedback occurs when we are working in the community directly, or having events, and especially being in person. So to start, the community would have defined what impact is first, because we made an assumption. And in addition, there are no Indigenous evaluation frameworks for long COVID impact. So for example, if I choose a measure that I as non-tribal think, yes, this is meaningful, these questions measure impact, but then a tribal member would define impact in a different way, the tool becomes not meaningful and it's not culturally relevant. So we tried to do the best that we could with the tools that we had, and also in addition to the restrictions with the pandemic at the time. The second thing is the collection process, where you're sharing the information for the study, how you collect it. So that's phone, letter, in person. That all impacts who can participate and the types of knowledge that you will receive. So the pathways that we use for communication were the same that we typically use all over the nation, and especially our department. And one of the main themes we heard was communication, saying that what you're currently doing is not working and you are not reaching the people that you need to be reaching. So finally, the community health reps are the trusted sources in the community. They already work with the members. Ideally, we would have had them asking our community, how is impact defined? And then the community leads us in the collection process, the analysis, interpretation, and the application. And so this process is often referred to, as you see here, the community-based participatory action research. It's kind of long. And again, this isn't perfect for Indigenous communities. You typically have to adapt it one more time and use an Indigenous evaluation framework, which I have an example here on the bottom if you would like to reference. All right, next slide, please. All right, final thoughts. So in summary, we learned that long COVID is complex. Everyone's symptom and impact experience is different. So be prepared for this, be willing to listen. These are people's lived experiences, a lot of loss and a lot of grief. So these are hard conversations to be having. The second thing is, when you're thinking about recovery and resiliency of long COVID, ask the communities, what would you like to do? What are the largest problems you see? The community will guide your process. You'll want to identify what current resources you have, because you may or may not be able to do best practice, but that's okay to adapt. You'll want to frame your communication narrative on the values of what your community identifies, and identify vulnerable populations. So for us, this means using we statements, community-based statements, That is how we motivate our community. For some of our vulnerable populations, this would be elders, youth, eminent speakers. You might also consider other places of social disadvantage, such as those living with a disability, those with lower socioeconomic status. And finally, I've already said this before, but I will hit on it again. We heard it all over the state. I heard it nationally related to the pandemic, that communication is so very, very important. And when we are looking for leaders to help guide these processes and communicate what is going on in the community, it doesn't necessarily need to be, me who's coordinating the study, or in a client setting, usually it's a doctor or other government officials. And just because you have a certain educational level or a power from a leadership position, that does not automatically mean you gain trust. So we would recommend using communication messages that are in plain language, culturally relevant, and using pathways that communities trust and have confidence in. So this means looking at things like social media in comparison to letters, radio, in-person meetings, etc., and looking at who is the one sharing the messages. So this could be someone who is a formal or informal leader. It would just be whoever your community trusts, has confidence in, and identifies with. And that is all. Thank you. Punagigi.
All right, now we're just gonna pass it over to Dr. Antoinette.
Hi, good afternoon, everyone, or good morning, depending on what time zone you're at this moment. My name is Dr. Antoinette Francis Shearer. I'm the Health Education Manager attached to the Center for Healthy Communities at the University of South Alabama in Mobile. Yeah, go Jaguars, go Gulf Coast. Next week. So just a little bit about the Centers for Healthy Communities. Our guiding principle is to engage the community to find actionable research and educate them on health matters and what it takes to be healthy community. At present, we're involved in several projects. For instance, the All of Us research, which actually deals with health equity, in that the All of Us research project allows members of the community to enroll in a research program that is run by the National Institute of Health. And we collect samples so that we're able to provide more precision medicine and help researchers find out what is off the mainstream, what you, as if you're not part of the mainstream, what your blood needs are, how different diseases impact you. We also have our community health advocates, where we work with community leaders and help them to disseminate health education. And we also have a program, Stars and Stripes, where we go to the youth and train them in the ways of health, how to in career, as a career path, and also how to share that health message with their schoolmates and their family. Next slide, please. So with all of that community experience, we have become collaborators with Mobile County Health Department. They were fortunate enough to get the CDC RFA DP21 109, that's a big mouthful, but the community health worker grant to deal with, so that we could look at resiliency for the Mobile community, the communities in Mobile at the time, to build resiliency to some of the inequities that came up as a result of the ravages of COVID-19. The grant currently services 13 zip codes. The zip codes have a range, the diversity that is Mobile. We have some of the very rural areas. We have some areas that also border the tribal nation, the Choctaw Indian, which is state recognized and not federally recognized. So they are able to always use our partners, Mobile County Health, for their health needs as well. And we even have Laotian and Vietnamese enclaves in our very southern Bayou Battery area. So it's the 13 zip codes were where COVID prevalence was high, and inequities, the health inequities were also high. So the community health worker grant was a step towards bringing redress and balance to that. Mobile County, as you can see, has a higher average of uninsured than the national average, which is at 9.5. And Mobile County also currently has a higher level of poverty at 19.3, which is higher than the national level, which is 10.5. That speaks to why the health inequities are happening from a social determinant of health standpoint. And as a public, any one of you in public health know, when we're talking about the social determinants of health, that explain that when it comes to disease and dysfunction, only 20% of it is actually physiology and physical. The other 80% squarely lands in the environment and the processes that we as humans have to endure in our communities and our neighborhoods. Next slide, please. So a little bit about COVID-19 in Mobile, Alabama in 2022 as of August 17. And this information is taken from both the CDC dashboard and the Mobile County Health Department dashboard. 50.9% of the total population is now fully vaccinated. The CDC defines fully vaccinated as these persons have had the first and the second dose. It does not, that full vaccination does not take into account the booster dose. And when it comes to booster dose, currently records show only 37% of the Mobile County population has at least one booster dose. This is good. This is important for us because come fall, as you may have all heard, the CDC and the federal government is going into a sort of booster population. And why boosters is important to this long COVID conversation, because still the best way to prevent long COVID is to prevent COVID altogether. And I take a pause now to let you, Courtney, we do have a long COVID document that we're gonna share with you. My colleagues from the SEAL grant at the Center for Healthy Communities have been sharing a document with some of the pastors and our community health advocates about long COVID, and we're gonna share those with you so that you can have conversations even after we leave today. The current, back to Mobile, the current precautions for where the community level of COVID infection is high are really very simple. You wear a mask indoors, not outdoors. Wear a mask in public transportation, buses, on airplanes. If you have to take a commuter train, you should do that as well. You get tested if you have symptoms. And if you don't know where to get tested, there is a wonderful national tech service that the CDC has set up. It's basically Get Vaccines, but you can text 438-829, text your zip code where you're living or where you're staying to that 438-829, and it will give you a list of the nearest vaccination sites to that zip code. Also fabulously, the Mobile County Health Department has a Mobile County Health app that you can sign on to. So if you're in Mobile County, and it's available on Android. So if you're in Mobile County, you go to the Android Play Store and you can download the MCHD app, and it can also help you get a vaccine appointment, tell you where a vaccine appointment may be in this mobile localized area. Next slide. So let's look. You think you've been exposed to COVID. This is what happens. Individuals infected with COVID have a series of symptoms that they show. The symptoms, if they last for longer than 4 weeks, initially the CDC proposed 6 weeks, and a lot of medical doctors still stick to that. If it's 6 weeks, you experience several long-ranging symptoms. The symptoms you get are usually based on any pre-existing chronic ailments you have. We've seen symptoms are based on your vaccination status, and some research is coming up showing that there is even there seems to be a skew of long COVID suffering by gender, in that females are experiencing more symptoms of long COVID than males. That they still have to investigate that, because as we know, more females tend to have health-seeking behaviors. It's harder to get the men in to measure and therefore to monitor and make a more holistic view. But as it stands, that's what the data is showing. Long-term effects from COVID, as I said, are more than 6 weeks. And it's important that CHWs or promotores or these community health representatives all become very conversant with the names it's called. It's called post-COVID, long-haul COVID, post-acute COVID. And why is that important? Because particularly like in Mobile County here, where we have a maritime population and there's a great mix of diversity and an intermix of international and local and regional guests, you're never quite sure about the literacy level or the cultural references. So be aware as a community health worker, promotora, or a community health representative, learn all the phrases that long COVID, that refer to long COVID, so you can help someone if they come to you for that. Next slide, please. Very key, what has come up very key for some of our CHWs here is also if you're long COVID and asymptomatic. While most long COVID sufferers have been known to have tested positive for COVID, there are some people who have never tested positive and they still have long COVID. And it's important to know that the key in that sentence is that they have never tested positive for the virus. But we are aware that there are several asymptomatic persons who've been infected with COVID and have no symptoms, and therefore they don't test or they don't even know they have it. If you think you may be one of those persons, how you find out if you had COVID is generally when you take an antibody test. The antibody test, it is available from a home. There are home kits for antibody tests, but generally it's better, it's recommended that you go to a pharmacist or a medical professional to get your antibody test done. The antibody test will tell you if you have been exposed and therefore give some context as to some of the symptoms you may be feeling at the time. So basically we can tell you if, yeah, you're suffering from long COVID as well. It should be noted that immunocompromised individuals may not be able to take this antibody test, and for that reason, that exception, they may have to consult with their own medical professional, their own doctor, to find out how best they can put their symptoms into context. Next slide, please. So this is what long COVID looks like. We have a range of, as Sarah pointed out, a range of physical symptoms, vomiting, sneezing, loss of appetite, rashes. There's a range of things like sleep disturbance. It's in the head. There's a range of cognitive symptoms as well. Sleep disturbance is still one of those, but also mental fog and mental fogginess. And then there is just this plain exhaustion. That long range and this list of symptoms was compiled by a long COVID conference that was held in Southampton, England earlier this year. And so this list of symptoms actually at this point keeps growing because we're learning new things even as we speak here about long COVID and how it's impacting those who are suffering. Next slide, please. So let's just take a look at right now some of what's happening in the US, in the community, persons like you and me with long COVID. We listen to this video.
This is all hands on deck.
When we started taking care of the patients in the acute setting, we thought that things would get better and they'd move on with their life.
Big breath.
And now we're seeing these long haulers, which we thought were going to be a small proportion of patients, and it's really not.
It's somewhat frightening because we don't know what we're dealing with.
I get this nausea and I don't have any energy.
Breathe.
We could potentially be seeing here the origin of a very significant number of people with chronic illness.
One of the most challenging aspects of being a long hauler is getting all the nutrition you need.
It kind of hit me that we were onto something bigger, a second pandemic, as it were.
So all we can do is pray for a miracle.
I remember the day like it was yesterday. Doctors told me that if I had COVID, to rest and I would be better in 2 weeks. And sadly, those 2 weeks have not come yet.
It wasn't my dream.
Everything has changed. I have not been able to work in almost a year.
This is what my life is like now, walking in the basement for enjoyment.
While many people who are infected with COVID recover, for some, their symptoms persist many months after the infection.
So I just finished a 30-minute phone call, and it feels like I have a fireball in my chest.
You know, some weeks I'm feeling a little bit better. I'm like, okay, I think I can go to the store. I think I can go for my 10-minute walk, but nothing more than that. And then there's weeks like this past week where I was just in bed all week. And so it's agony and it hasn't, completely gone away. So it's a game of like snakes and ladders. I started hearing about some of these online COVID groups. Young people, never hospitalized, mild illness, just like myself, technically. And that was like, oh my God, this is happening to hundreds, thousands of people.
A recent study found that 1/3 of COVID patients report having persistent symptoms. That's as many as 8.4 million Americans. These long haulers no longer test positive for COVID, but feel the lingering effects of the disease, often in a debilitating way.
Another part of my day-to-day life is waking up almost every night when I wake up in the morning, and coughing my face off.
Ugh, just feeling real yucky. I hate it. Drains every piece of me.
If you've gone from biking 10 miles a day and you can only walk 10 minutes a day, to me, that feels like the life of an 80 or 90-year-old.
We see a number of people that were normally functioning people, very active, healthy, exercising, and now they just really can't get back to where they were, and months have passed.
Before COVID, I was signed up for the 2020 Chicago Marathon. I've been doing everything I should. I've been doing the right things for my body to be able to take this on. And for some reason, it's not. It's still fighting almost a year later. I get out of breath really fast. I can't go on a small walk. When I had realized that I was part of this this group of long haulers was really when I started connecting with my doctor at Northwestern, Dr. Sala.
Hi.
Hi.
It's good to see you.
You too. I have this cough, just that I wake up and I'm like, okay, I feel it.
Kind of this sense that you can't take a deep breath in, like after a long period of conversation.
Yeah.
Across the country, doctors at more than 80 post-COVID clinics are trying to understand why so many people can't fully recover after COVID.
This is all hands.
All right, so that is on a patient, and doctors are still trying. Long COVID is still being understood. So let's have, what do CHW conversations have to give you when you're doing this? It's a great pivot point to remember some of those CHW training skills you have and to understand what your role is in the multidisciplinary team. First, long COVID, when your clients tell you about long COVID or mention long COVID symptoms, it's that's a point where you practice active listening, as in just listen, because a lot of our long COVID sufferers have said they aren't being heard. And that has to, in a community like Mobile, and where there's high African American population groups of, and also some of the tribal groups or some of the other ethnic minorities, it's important to listen because those populations already feel that there is some trust issues and they're not being heard. It's also, as a CHW, you practice your self-advocacy and also advocacy of empowerment to the community. You should encourage clients to write down their bouts and their bouts of what they're feeling. If they feel nauseous, how long they feel nauseous. If they're feeling sick, how long. If they're feeling tired, if the exhaustion lasts every day, or if it's only 1 or 2 or 3 hour period. Have them write it down. One of the great things about also our partner, Mobile County, the health department app, is they actually have a sort of journal feature in their app. So again, if you're in this area, please feel free to download that and learn to use those tools. Encourage your clients to write them down. That way they can discuss it with whichever member of the healthcare team they're meeting at one point. It's also, long COVID conversations, also a great pivot point for vaccine compliance. Again, I will say the best way to prevent long COVID is to be vaccinated and keep up with your vaccination regime, because they have shown that long COVID occurs more in non-vaccinated persons than it does vaccinated persons, right? The last point I want to say is the conversations on long COVID are also perfect for talking about mental health, ways to express fear and rage, particularly because long COVID sufferers often talk about mental fogginess, fatigue, and sometimes spasmodic blackouts over just random blackouts of where they're going or what they're going to do, or they just can't recall huge parts of their day. And that fear and rage is important, because persons who are in lower incomes, or anyone, when they get sick, the promise is that they will get better. And when they seem not to be able to get better and get back to their regular routine, that brings about fear and that brings about rage. And the reactions that come from that may not be the best to the community. So I would highly recommend getting some mental health first aid training, but also learn to pull in other members of your team, the mental health counselors, the therapists, all those professionals into your referral circle. Next slide, please. Remember also, long COVID, because of its physical impacts, is now covered by the Disability Act. And in particular, when you're thinking about large senior population, There is an aging and disability resource center that is available in several regions of the US. You can help locate the ones that are closest to you by calling the 800-677-1166 number. Those get the elderly things like transport, access to funds for transport, or access to other agencies that can help them as they manage their long COVID system. Next slide, please. And so the last point, the talking point, after all is said and done, after all you've learned about long COVID or heard about long COVID, we should understand several key truths. Long COVID is not homogeneous. No one person seems to have the same symptom. No set of people seem to all have the same symptoms. They have similar symptoms. So different persons, depending, as I said, on their vaccine status, their pre-COVID health status, even their gender, different persons, different impacts. Write it down so you can ask them to write it down to find a path to wellness. Remember to also be open. This is not just you and the client against the world. Learn to bring in other people into that healthcare team circle. So this is the point where occupational therapists, mental health first aiders, and even helping people learn about video and telehealth appointments if they're too tired or too fatigued to go to physical appointment. That is key. And learn to delegate, have your clients delegate so that they can conserve their strength and do the best that they can. Last two things are very personal and subjective. Because you learn to find joy and smile every day. Find a moment, perhaps start your own gratitude journal. Or if you're regardless of where your creator is, learn at the end of a day to thank him about the one thing that made you smile today, or the one thing that you were thankful that happened in your life today. Last but not least, particularly for those of us who don't get enough sleep, and that would be another webinar. Learn that, and this is a quote we got from an older person in this area. Learn that nothing in the nothingness, healing can whisper. And that is, learn that if you're feeling well, it's okay to say no and just be quiet, be still, be silent, and allow your body to heal. And if you can help your clients understand that too is okay, it's okay to do nothing and just allow your body to heal, we will be on a good path. Thank you for listening. Have a good afternoon, everyone.
Thank you, Dr. Antoinette. So now, at this time, with all the information that we've heard from our two panelists and even the information earlier, if there's any questions that folks have, this is the time. We have about 10 minutes to have a Q&A. So if you would like to write those in the chat, you can, or if you would like to come off mute to ask your question, we definitely welcome that. And if you are asking your question on camera, if you're coming off mute, if possible, you can come off camera just so we can interact, but definitely ask those questions now. So it looks like we got a question in the chat. And of course, the vision team, y'all can help me get some of these if I miss any. So the question for Sarah from Chirpau, from Sheboygan. Sarah and Dr. Antoinette, do you have any specific materials for CHWs to work with or help people who are suffering from long COVID?
So I think one of our colleagues on another grant at our center has developed sort of like a talking sheet, just a quick reference. Courtney, you may have that on PDF, and that would be available on the app. We do have some stuff. But what's important to remember is also that because long COVID is not homogeneous, so to speak, that it can differ based on the individual circumstance. I think what may be required is for any CHWs first, you listen to what the sufferer is saying. Because if is it physical, is it cognitive? You help them based on what they are saying.
I can also chime in. My approach would be a little bit different, the perspective that we have. So the resources that I would have would be more for providers, for clinical staff when speaking with patients on some of the questions that they can talk about on the impact or specific symptoms that you should be looking for, since it is so diverse. In terms of the community and public health route, oftentimes it's again communicating about vaccine confidence and what long COVID is. And some of the materials that we've been doing for that come directly from Indian Health Service or the Urban Institute of Indian Health and things like that. So if you would want those resources and they are relevant to the community that you're serving, I have no problem sharing those. And I could send that by email later to share out with the rest of the group.
And then we have some more in the chat, but I do see Clifford, your hand is raised, so you are more than welcome to come off mute and ask your question.
Yeah, so I was just wondering, Cliff Ryan out of Syracuse for 1199. I was just wondering, with the information that is being given today, will you be sending out information via paper trail, like flyers and different information pertaining to the discussion today, so that we could distribute in our prospective cities, to get that information out as well.
Yeah, so I'll let our panelists speak if they have anything extra, but yeah, so a lot of those links that we're dropping in the chat, specifically some of the flyers and resources that Dr. Antoinette has shared with us are presented in an infographic or flyer type way, and then also that Envision doc that has been dropped a couple of times, and we can drop it again, has a link to additional information, additional flyers around long COVID that we've been finding. And then they were also given to us specifically. And I guess, Dr. Antoinette, do you want to maybe speak to those resources, those PDFs that you mentioned earlier a little bit?
So we would have to, so we would have to print it out. Is that what you're saying?
I guess it depends on maybe how you're distributing, because if I remember your question, did you want them to print them out, or would you just looking to?
Yeah, that's what I was pertaining to. Okay. Like we have flyers that we distribute pertaining to the COVID information, and I was wondering if that PDF would allow us to print out the information so that it can be distributed, or does any of the doctors who are presenting have ways to get that resource to the prospective cities to be able to distribute?
So the PDF, yes. Some of the stuff is on AMP, isn't it, Jamal?
Yep, so everything that we share today will be available in AMP directly, as well as in follow-up emails.
Okay.
Yeah. And you are able to print those as well.
All right, thank you.
Let's see.
There is a question in the chat about whether the variants COVID variants and long COVID. So there has been some work done on that, but it's inconclusive. Current work suggests that Omicron may have been more long sufferers from the Omicron variant than the previous variant. But again, that research is not conclusive. There's not a wide enough population pool. So to Victor, my answer to you is we are still researching that. There is no conclusive answer to the link of variants and long COVID. I don't know if Sarah has found anything in the Indian Health Service or the Tribal Nations Health Service.
Yeah, so it becomes really challenging when you have all of these different factors coming in, especially when we're looking at different populations, and the United States or even the state that you're living in is trying to use information from other countries. So what I would say related to that, I haven't found anything specifically. The variants make it just very challenging to predict someone's outcome, and also the interplay of their health status and their health behaviors and the access of resources and things that they have. The only point that I will piggyback onto this is in terms of immunity. So there was messaging going around in the state that some people, we still push that the vaccine is the best way for prevention. Like we said, the best way to get it is to prevent long COVID is to not get COVID at all. So in terms of immunity, some people think, well, if I have natural immunity, I can't get COVID again. And particularly for this most recent variant, Omicron, they were finding that the natural immunity was not lasting as long as the previous variants, excuse me. So they were really pushing people for this new suspected wave that's supposed to be coming in fall time, and with this updated booster, to be getting that booster.
And then there was a question right before the variant as well too, to make sure we get that. So by any chance, are there any trainings that are available in regards to long COVID? And if so, is there a point of contact for these trainings?
The short answer is yes. The long answer is that each health system, like the USA health system, which is the University of South Alabama health system. I know up in New York City, Cornell and Mount Sinai have done some. So each different regions are handling training for long COVID differently, and long COVID, like everything else to do with COVID, has to be taken from both the medical and clinical perspective and from the social perspective.
Hi, my name is Manuel. I'm here from the Public Health Department here in Tenerife County, but we're based off in the West Coast here in California, and I was actually the one who asked that question regarding any trainings. So what we're doing is we work with our CHWs, and we're working on a grant, right? And I guess the basis more of the question has to do in regards to we kind of, one of our trainings that we want to implement in the near future is that it's actually regarding this topic, long COVID, right? And I know that right now there's probably not as much like data and as much, like research on it or whatnot, but I did, Dr. Anthony, I did like the presentation that you did actually today. And that's why the question, right? Like if there's maybe a point of contact, or if we could keep in touch, or if there's like an email or something and we could reach out to you, because I mean, I like to connect with you guys and see if maybe you guys may be available to do some type of training, maybe even something similar to this, right? Again, if you guys are open and willing to do it, we'd like to work with you guys if possible, or connect.
Yeah.
Sorry to put you on like blast like that, but
that's fine. Yeah, sure. I can drop my email in the chat and reach out, and let's talk about it. Awesome. I want to quickly just answer someone who spoke about another question in the chat I was asking about advocacy. Kayla, and the advocacy might have to actually come from the CHWs or from the health departments that have CHW. What we have seen happening in other parts of the world, in Europe, and even in the Caribbean, and so, is that they found a lot of CHWs have found support groups, as in groups of if you have several clients or several clients who are suffering, who may be suffering or experiencing long COVID symptoms, they have support groups that meet where they discuss what they're feeling, how long they've been feeling it, and the sort of thinking that's happening. And they also share resources about how to cope and how to manage. And that's a great way to get members of your team to come in, because you can have the occupational therapist come in and address the group. You can have the psychologist or even the internal medicine specialist come in and talk about breathing to the group, where they may be afraid or unable, they can't afford going to that person on an individual basis. Excuse me.
Is there a website to get some more information on the long COVID?
CDC has one.
CDC?
CDC. And all of those, and I just want to point out, Charles, all those links are directly dropped. And of course, reminding folks to opt into our listserv. And that is all the time we do have for questions, because we do have to launch our poll. So our presenters drop their information in the chat, or if you don't mind just dropping it again so folks can get that. We will follow up with everyone that's here through email and making sure you get all the resources that we have. In that document that has continued to be dropped had quite a few resources around long COVID from the CDC, from Dear Pandemic, from Dr. Internet, and yeah, really great resources. So definitely want to thank our presenters once again for coming on and giving an amazing presentation on long COVID and everything that it is, which can be a really confusing thing for many populations and our CHWs who are continuing to work with folks experiencing long COVID. And also just want to point out that, all our presenters today were directly connected to us through CHW leadership and community. Specifically, Sarah was connected to us through one of our CHW council members, Lynette, and we learned of Dr. Antoinette's work through the Nashua virtual conference. So, all right, so this time I'm going to launch this poll quick because we are almost out of time, and you all should be able to see that and fill that out. And of course, after filling that out, you all are more than welcome to just hop off. And we thank everyone for coming today and joining us in the long COVID conversation.